Okay, we're going to go ahead and get started. I want to thank you all for attending today's monthly MCEDA webinar on creating the lean and efficient medical practice. My name is Bruce Mackey, and I am today's moderator. Before I introduce today's presenter, I have a few housekeeping items to address. First, I am about to send you guys a link. Anyone, if you look in your chat window, I've just sent everyone a link to today's slide deck. There's a PDF version for anyone who would like to print it out and follow along. It's a request we get almost every time. Additionally, this PDF can be found on our website at mceda.org under the Resources tab and then Webinars. Throughout today's broadcast, we will keep the phone lines muted to minimize any background noise. If you have a question for our presenter, please use the chat window of the GoToWebinar interface to submit your question. At the end of the presentation, we will address as many of the questions as time allows. If we run out of time and cannot answer all questions, please know that we log all questions and answers in a digest and distribute that to all attendees within a few days of the broadcast. For any attendees who are not aware of who MCEDA is and what we do, I'd like to take a moment to introduce our organization and briefly touch on our breadth of health IT services. As Michigan's sole regional extension center, we are an independent nonprofit organization providing technical assistance, guidance, and information on best practices to support and accelerate providers' efforts to become meaningful users of certified EHR technology and have a top-notch team of highly experienced professionals focused on the triple aim, which is improving the patient experience, improving population health, and reducing healthcare costs. This slide briefly describes our services, which include meaningful use support, all stages, all years, the security risk assessment, which is part of the meaningful use requirements, but is also a standalone service that we can provide. Targeted process optimization, which is really the focus of today's presentation, as well as audit preparation. We're getting ready for a meaningful use audit. We can help. Today's presenter is Chris Calderon, MCEDA's lean healthcare consultant. Chris brings an extensive background in leadership development, change management, operations, strategic planning, employee engagement, and project management to our team. His extensive experience includes lean and performance improvement work at Allegiance Health and the University of Michigan Health System. And with that, I would like to turn things over to Chris.
Thank you, Bruce, for that kind introduction. So again, on behalf of the MCEDA team, welcome to our webinar today. And I just want to kind of get started straight away and go over some of the discussion points that we want to cover in our short time together today. So first of all, we're going to give you an overview or introduction of lean thinking for healthcare. Now, you're not going to walk away today as lean experts or performance improvement experts, but I do want to talk about how some of these specific lean process improvement techniques can be applied to a medical practice. We're going to talk about some of the common pain points and barriers that you experience in your daily work within your practice. We're going to talk about forms of waste within a practice. And then probably most importantly, we're going to talk about specific techniques that you can use and methods that you can use to start improving some of your processes and workflows within your practice. So let me just begin with a brief definition of what lean is. It's really a performance improvement or PI approach that focuses on reducing the different forms of waste that we're going to talk about today. And it's also applying some of the concepts and principles and specific tools that we're going to cover today, helping you provide the most value to your customer, to your patients, to each other. And so this is commonly referred to as lean thinking. It's been widely applied to many areas of healthcare throughout the healthcare continuum. And I think, I'm not sure if it's an irony, but it's interesting to note that a lot of the folks, the organizations that are actually paying for your services are applying lean techniques as well. So as we think about the program today, I'm going to really pose 5 questions that we're going to try to answer as we go through the slide deck. And the first one is it possible to get rid of some of the non-value added stuff or the waste that we do within our practice operations? Can we improve processes so they're more efficient, more patient-focused? And then very important, obviously, can we free up time for our physicians? And then can we reduce some of those barriers that we're going to talk about that cause staff frustration and perhaps patient dissatisfaction? But really, the context of our discussion today is framed around the notion of patient flow. So I'll spend most of my time talking about patient flow in ways that we can improve patient flow. Now, so let me just briefly define patient flow or provide some context around patient flow. It's really a process or a set of processes in terms of how patients enter, move through, and exit the practice. And when you think about an ideal flow, in my mind, it's characterized by there's less waiting for patients, for staff. We're not stopping and restarting as much. We have less handoffs, right? So we're not handing off information, paper, and of course patients. There's minimal duplication in terms of tasks, and there's minimal time spent searching for information, for things. Some of you may be even searching for your employees from time to time. And then, of course, it's also about reduced cycle time. And so this notion of cycle time is very, very important. Each of these areas that I just mentioned are really ideal for a focused lead improvement approach. And then the thing to think about, too, when we talk about patient flow, it's measured in cycle time. So when you think about a hospital, they're always talking about throughput. Throughput's a concept. Patient flow is a concept. Throughput's measured by length of stay. Patient flow is measured by cycle time. So a note about cycle time, and I'm sure some of you do capture cycle time, but I've been in a lot of practices where we really don't capture cycle time. So cycle time is the time from the patient entering the practice or signing in until they actually exit the practice. And depending on what study you look at, some of the work I've been involved in, the average cycle time is anywhere from 30 to 90 minutes, and of course it's much higher in some of the specialty practices. But the key point I want to make here is that cycle time really is made up of two components, and those are value-added things, the things that add value to patients or things that patients are willing to pay for, if you want to think of it in those terms. And then there's the things that are wasteful, the non-value-added activities. So think about non-value-added activities as the resources and time that you spend that really prevent us from optimizing patient care, and I think very importantly prevent us from optimizing the time of the physicians. And so here's some basic examples: a slow scanner, slow computers, a very paper-intensive environment, and even last-minute cancellations where we're not prepared or set up in a way that we can fill those last-minute cancellations. They impact capacity. So those are some things in terms of specific forms of waste. Searching, we spend a lot of time searching, or what I call hunting and gathering activities, whether it's test results or other information. This was from an actual practice a while ago. And then some more examples of waste. So we're adding extra and often unnecessary steps to a patient registration process, taking too much time to schedule appointments. So these are all forms of waste that have a direct impact on patient flow and revenue, and also staff and patient satisfaction as well. And so think about this, and it doesn't matter what part of the healthcare continuum in which we work, about 50% of the stuff that we do, we could probably minimize, in some cases get rid of altogether. Now, there's a lot of things that we do, we have to do them, yet a patient isn't willing to pay for it, or a payer isn't willing to pay for it. Those are things called essential non-value-added activities. So think about anything with the government, anything regulatory in nature, maybe payer requirements, maybe legal or administrative. So there's really three categories. There's value-added, things that we need to do that a patient or other staff member values, essential non-value-added, things that we don't need to do, but we have to do them because of government or regulatory. And then the non-value-added, the pure waste, and that's what we're trying to get rid of. And I'll talk more about that as we go through the slide deck. But I just want to loop you back to this concept of waste. And there's really 7 categories of waste, and use the acronym, the name Tim Wood. So you have the waste of transportation. This is the waste of moving things around, moving things from point A to point B. And I'll have some specific examples here in a second. The waste of inventory, maybe we have too much stuff, too much supplies. The waste of motion, this is people moving from point A to point B. And I use the example a lot working with nurses in inpatient settings. On an 8-hour shift, a nurse will walk almost 4 miles. And the point there is that some of that is wasted footsteps. The waste of waiting, we spend a lot of time waiting in healthcare, waiting for the next step in the process, waiting for the next caregiver, waiting for information. We do a lot of over-processing. An example here would be duplicate charting. And then sometimes we overproduce. Maybe we're ordering too many tests. And then, of course, the waste of defects. Those are errors or mistakes that often require a redo if we catch them. and of course that is huge in healthcare. The waste of defects and the waste of waiting are two big forms of errors that we are forms of waste that we see. So here's a chart to kind of give you a little more context. And I'm not going to go through the entire chart, but I do want to point out I've added another form of waste, and that is the waste of confusion. So when you think about processes, and I'm going to talk about standard work coming up here shortly, but when you think about a process or procedure that's not formalized, maybe there's inconsistency in terms of how people perform in that process, whether it's in a chart prep area, whether it's in a registration area. There's not a lot of clarity in terms of who does what, how they do it, and when they do it. So there's confusion as another form of waste. Now think about at the top when I talk about errors, there's really two types of errors in healthcare. There's errors of omission and errors of commission. So an error of commission would be when you're kind of semi-awake on the operating table and you hear the surgeon say, oops, that's an error of commission. They made a mistake and they caught it. An error of omission is when we forget to do something, and errors of omission are the most common. So when we talk about standard work coming up here shortly, we'll talk about how to reduce those errors of forgetting things. So think about this in terms of waste identification. I asked the question, where's the waste in your practice? And so we have a tool called the waste identification tool or exercise, and it's really an important starting point because the premise here is that before you can get rid of the waste, you have to be able to see it. You have to be able to recognize it. And so it's a very easy tool that can give you some insight, and this is sort of what it looks like. And I'll give you an example. We have the categories of waste on the left-hand column, and I'll give you an example for motion. I'm not sure how well you can see that from your screen, but a waste of motion, I mentioned a nurse or an MA walking from point A to point B, perhaps looking for a chart. That's the description of that waste for the category of motion. And then a justification would be it's waste because we're spending about 20 minutes per day extra looking for something, looking for a piece of paper or looking for a paper chart. I talked about over-processing earlier. An over-processing example would be asking patients the same questions over and over again. That redundancy and duplication is the justification as to why it's waste. So that's a tool that's available, that will be available to you. The other thing, too, I talked about cycle time as kind of that measurement component of patient flow. And so just to reconnect here, cycle time consists of a lot of waiting, a lot of delays, the stuff that doesn't add value. They're starting and stopping. We're waiting for the next person. We're waiting for information. So the question I pose to you is how can we decrease cycle time? How can we minimize some of that waste that I talked about up to this point? So I'm going to kind of walk you through some additional details around reducing that waste. But I just want to talk about cycle time quickly here. So it's pretty easy to determine. And for those of you that aren't getting cycle time, you don't have to record it indefinitely forever. Really, you just need a snapshot. And it's as simple as recording the time when a patient first signs in and then recording the time when they exit. And maybe a week or a 2-week sample would be good. Now, the question here is, okay, so I know what my overall cycle time is. So what? And that's a good question. So there's value in knowing what that overall cycle time is, but you have to understand some of the timing and sub-processes within cycle time. So let me give you an example here. So the patient checks in, that cycle time start. They leave the practice, that cycle time stops. But what about when the patient first gets into the waiting room until they're called in by the MA or whomever for maybe for vitals? How much time elapses from patient waiting room entry until they're called in? How much time elapses between patient sign-in until they actually get into an exam room? And then how much time from exam room entry until the provider sees the patient? So these are sort of sub-cycle times, if you will. And these are very important to monitor and get a sense for how you're performing as well. And interesting to note here, a lot of the research shows that patients will tolerate about 20 minutes of wait time. Once you hit 10 minutes or so, their loyalty becomes a little bit challenged. So just an FYI there around wait time. Also, in terms of the economics of waste, and so the premise here is if we can shave a few minutes off each patient visit, recognizing that on average each patient visit has 2 to 3 minutes of waste built in, basically, those seconds and minutes can really add up quickly. And when you think about patient flow, really we're in the hunt for seconds and minutes in our daily work. So everyone in the practice, regardless of your role, everyone that touches the patient has a part in reducing that cycle time, and of course the role of the physician is especially important. So if you think about a physician, if you think about who the patient is coming to see, obviously that physician, is that caregiver, that's the person that's billing for the service, and so your practice revenue is essentially a function of how well the physicians are using their time. And so there's some more research to kind of support productivity of physicians, not that we're picking on physicians at all, but typically, and if you talk to a lot of physicians, this is where some of this information comes from, is interviews with physicians and observation, they'll tell you that they feel on average they're about 70% productive, about 20% of what they do could be delegated to someone else, about 10% of what they do is wasted. So they're looking for forms, they're looking for phone numbers, they're looking for information just like the rest of the staff. So just some context around the physician's time in terms of waste and what could be delegated as well. So whether you're a practice manager or a physician leader or an office manager, whatever your title, we're always concerned about how to best maximize the physician's time. And again, all of the processes, whether it's patient flow, chart prep, referral management, they're all really built around how we can maximize the physician's time. And so I asked the question earlier, or just threw it out there, what do patients want? And it's that time with the physician or patient-provider time. That's what matters most to physicians. So as we're talking about how to look at our flow and perhaps redesign it, that should be the thought at the forefront of our minds in terms of how can we redesign patient flow to really maximize the time that the physicians have to take care of patients. And a lot of small changes are really going to add up. There's not going to be one single thing that you're going to do that's going to totally transform your practice. But here's some examples of just little things and how I like to say little things really matter. And one is reducing excessive footsteps. So I alluded earlier to the phrase hunting and gathering. A lot of the waste of motion is spent searching for things and gathering information. And so little things in terms of physical layout of the practice, how we've designed our rooms, in terms of making sure that we have the right stuff in the room when we need it, and this is called the point of use concept. So if you think about your kitchen, where you store your pots and pans, they're not in the living room, at least I hope not. And then the other thing that we like to focus on as part of a lean context is a concept called 5S, and I'm going to talk about that shortly. So part of this, too, involves assessing our walk patterns. So you can see my little diagram there. This is an actual walk pattern study. Those squiggly lines represent what we call spaghetti patterns, and that shows the waste of, or the movement or motion of people from point A to point B. And you'd be surprised how much efficiency or footsteps you can gain simply by looking at how you've laid out your furniture in some of your key areas within your practice. So I want to talk about this concept called 5S. The 5S words are actually translated. They were actually Japanese words because that's where lean kind of got its start in the Toyota and actually Henry Ford production system. But these 5 words have been translated to mean sort. So we're making sure everything is in its place. We're straightening out everything. We're making sure everything is clean. We've standardized how we keep things in order. And then we have a method to sustain the organization that we've created. And the important thing about this, it may seem kind of marginal, but there's a lot of research out there, and based on my experience as well, I've seen this firsthand, that when we have a cluttered, unorganized workplace, that has a negative impact on productivity, quality, and safety. So there's a direct correlation between how well our area is organized and how efficient our workflow is. And the other thing, too, is that people feel better when they come to work in a very highly organized work area. So we like to say, go through and declutter areas, whether it's exam rooms, closets, declutter, get rid of the stuff that you don't need. And I can certainly provide more context around the 5S notion or concept. And keep in mind, too, that some of these concepts I'm talking about, we could do webinars and seminars just on some of these concepts alone. So if you want more information, at the end we'll give you a way to reach us. So simple concepts. I talked about assessing office layout in a way that you can minimize footsteps. Another thing that we're seeing more and more, and it's very effective, is trying to get staff and physicians to work closer together in terms of physical proximity, and that just has some obvious improvements. And one is your communication or messaging delays are greatly reduced. Your tasks are more coordinated. So these are small things that really make a difference. And here's kind of a visual to bring the 5S principle or concept back into context for you. So the drawer, the before drawer is just a mess. We can't find everything. On the after drawer, we use dividers, and we actually have labels on the bottom, and stocking relevel or stocking reorder points are indicated as well. So if I'm down to 2 rolls of tape, I know I need to replace it. So little things like that. And again, you're in the hunt for seconds and minutes in your workday, and some of these little changes can really add up. And they could actually have a good psychological effect on your staff as well. So when we talk about 5S in terms of sorting, the first S, our saying is a place for everything and everything in its place. So if your office looks like this, you need to 5S your office, and it should look like this. And by the way, there's a lot of research to show that about 80% of the stuff that comes across our desk we no longer need. We just kind of hoard it. So just food for thought in terms of 5S. So I talked about patient flow, gave you a few general lean concepts here. I'm going to give you a few more in terms of specific techniques you can use. So how do we get started if we want to take some of these lean techniques that we're going to talk about? How would we get started to really look at our processes within our operations? The first thing I recommend obviously is select one opportunity, one area, or one specific process. So we're talking about patient flow today. And so if you're going to improve patient flow and cycle time, the first thing you need to do is you have to gain a deep understanding of the current state. How do things currently work within your patient flow? And one technique we use is called value stream or process mapping. And so that's where you're actually recreating the workflow on a wall, basically using giant Post-it notes or a whiteboard. And you're capturing the workflow, you're capturing the sequence of events, you're capturing who does what within that workflow. And then also, if we're mapping patient flow, I find it very helpful to map the flow through the perspective of the patient and the people that are doing the work. So if I'm a patient, I go to point A, point B, and I'll give you an example here coming up. But here are some actual pictures of process maps or value stream maps in progress. The map on the lower right is actually a digitized version, obviously. So typically what you'll do is you'll start mapping the process using Post-it notes or a giant whiteboard, and then you would take what you've captured in handwriting and kind of reproduce it in a digital version. So here's a very high-level patient visit. I'm not going to go over this. My point in showing you this as compared to the other value stream maps is that generally when you do a value stream map, you're really trying to get into the weeds. You're really trying to get very detailed, as opposed to an overall patient flow perspective, which this map represents. So once you've mapped out a core process, again, patient flow, for example, you're going to begin to question the process. And so I always like to start off by asking, well, what are we doing? So those are the steps that you're capturing, and then who's doing it, when do they do it? So there's a sequence piece, and then how do they do it? How do they actually perform this work? What types of technology, tools do they use, forms, et cetera, resources? And then why do they do it this way? And so as a leader, or as a physician leader or a practice manager or supervisor, regardless of your leadership title, that's one of your most powerful tools is a good question. Why are we doing it this way? So we're challenging conventional thinking. And then once you've mapped it out and you've asked those questions with your team, you're going to try to identify some of the common traits or common barriers that we tend to see around that particular process. So again, in this case, it's patient flow. And so I call this looking for common characteristics of dysfunction or maybe suboptimal parts of the process. And you can see a lot of it's around waiting. So the patient waited a long time for the provider, whether it was a nurse or the physician. They waited a long time to be registered. They were moved around a lot. Patients moving from point A to point B. And then the provider was interrupted during the visit. I've had to fill out a lot of forms. patient perspective. The exam room didn't have what I needed when I needed it, so there's that 5S part as well. And then the staff searching for stuff, which is kind of related to that. And so important thing about a lean approach, or even, regardless of whatever performance improvement methodology you use, everyone, regardless of title, whether it's the registration person, the admin assistant, whatever you call your front desk people, registration people, medical assistants, everyone has a role in thinking about how can we increase value to our patients? How can we remove some of that waste? And so we like to say we have to get our staff to develop new eyes for waste, identifying barriers. And then the other thing, too, when you're mapping out a patient process or a workflow, you're going back to my discussion around non-value added versus value added and essential non-value added. So you're actually identifying out of those steps in the process map which are things that are absolutely essential, absolutely critical to providing patient care and to actually getting reimbursed for, and then which things are we doing that don't make sense at all and no one requires us that we do them. So the red dot things, the NVA or non-value added, are the things obviously you're going to try to get rid of. And then, of course, you're identifying the non-value added but required stuff as well. So when we're looking at the process map or value stream map, we're asking questions. We're uncovering opportunities, and there's actually a bigger list than this, but these are some of the heavy hitters. Where can we minimize the waiting? Can we resequence steps possibly? Can we merge or combine any steps? Can we minimize handoffs? And very importantly, can we eliminate steps altogether? And the point I want to make here, so I've worked with a lot of providers both in the inpatient or acute care setting and post-acute care setting, and a lot of our performance improvement work tends to be additive. We're adding on new steps or a new sub-process, and that can add layers of complexity. So we're always looking to make things less in terms of tasks and activities. We want to take things away whenever possible. This is huge. A lot of practices, believe it or not, are still very paper intensive. So can we perhaps leverage technology and minimize some of that paper? Now, a key point about technology, so think about this, and I love Bill Gates' rule. He says that a 21st century solution over a 20th century process will only make that process less optimal. So if you take technology and put it over an old process or inefficient process, it's only going to make that process more inefficient. And the flip side is true. If I take in modern technology and I put it over an efficient process, it's going to make the process more efficient. So my point here is technology is not always the answer. It's a part of the process. It's a process tool. The other important piece here, I'm going to go over this in a little bit of detail coming up, is this notion of standard work. And that's essentially when I have different people approaching a similar process, they're performing that work in a similar manner. And by that, there's very clear role identification in terms of who does what or what they're supposed to be doing. Our procedures and processes are formalized and well-defined. As I mentioned earlier, we call it formalizing the informal. And the other thing, too, and this isn't in your handouts, I threw this in at the last minute kind of to prompt my memory. So whenever I see a process in healthcare, and healthcare is famous for this, a lot of our processes don't have triggers built in. And by that I mean I don't know when to send my work on to the next person, and the person receiving the work doesn't always get actively alerted that the work has been received. So when you think about your processes, whether it's patient flow, whether it's in the chart prep area, or whether it's in scheduling, are there process triggers that have to be in place that might not be identified or formalized? And so this fax machine picture, so I was standing by a fax machine working with the provider, and I noticed the Coke can, empty Coke can, kept ending up on the floor. And so I asked them, why is that Coke can falling on the floor? And they said, well, that's our alert. That's our trigger. When the Coke can falls, I know I just got a fax. So, kind of a cheesy example of a trigger, but you get the point here. You actually have triggers if you have an exam room that uses the color-coded plastic signs that yellow or whatever indicates patient's ready for the nurse or ready for the doctor, et cetera. That's an example of a trigger. And so triggers are usually part of technology and software systems. So I call this slide the power of seeing, and I just love yogiism, so I thought this one fit. And one of the things that we recommend doing, and we've done in the past, and you want to do this obviously casually, is kind of observe your physicians and see how they interact with staff, both before, during, and after the patient visit. What are they doing? How are they doing it? How long does that task take? And also, how much walking is involved? And this is not just for physicians, this is for everyone. And so we've actually used pedometers before to capture distances traveled, and that's how we determine the nurses walk an awful lot of miles. But when you think about some of the things that we do in practices, particularly the larger practices, we spend a lot of time moving the waste of motion from point A to point B. I want to kind of pivot now and talk about what I call the traits of a lean practice. And so by this I mean if I'm looking at a practice and it's working very well, and the same principles apply to any part of healthcare, whether it's a department, hospital, or ambulatory care clinic, these are the things that we see as essential, or what I call critical success factors. And the first one is they monitor what matters. So they got a good sense of how their processes are performing by using metrics. And so these are some of the typical metrics we tend to see in a medical practice. And I'm sure some of you capture these, some of you may not. And I'm not going to read them each to you, but I thought these were some very basic and common metrics. However, there are providers out there or practices out there who don't capture a lot of these. So just food for thought in terms of what you're capturing. Another thing related to this as well is a patient flow dashboard. And so that would include these metrics in an easy displayable spreadsheet format that you're looking at every day to kind of better manage patient flow. So I promised I'd talk about standard work, so I want to come back to that now. So again, standard work, this is where our processes are formalized and documented well, and there's a lot of clarity around who does what, when they do it, where they do it, and how they do it, as I mentioned before. There's written documentation in terms of how each step should be performed within that process. And so having standard work is one thing, but you need standard work tools or guides as well. And these are essentially visual aids that kind of help prompt or cue people to perform certain tasks. And so we use checklists, maybe a process diagram that shows how information, materials, and people move from point A to point B, maybe a one-page document with key reminder points. My point about standard work and standard work tools is it really helps to drive consistency and operational discipline. And so I want to give you an example here. This is a checklist. And when I say checklist, I'm not referring to a piece of paper that someone fills out and turns into someone. This is an actual, sometimes it's poster size, it's posted right where the work takes place, and you would simply list the essential, what I call essential must-haves of that process. So for example, in a chart prep area, that's the title of my process. Here's the first thing I do. Here's the next thing I do, et cetera, et cetera. And when you have standard work in place, when you have standard work tools in place, this can help minimize the error of omission. It can help minimize the chance that people are going to forget to do something. And there's a lot of evidence and personal experience, too, that things like simple checklists or a key reminder document of essential steps that have to be taken, whether it's a poster format or a checklist format, they really can help ensure process consistency, regardless of where you use them. So the power of consistency. Consistency obviously is what I call a CSF, critical success factor, not just in medical practices, but in really any part of healthcare. And then standard work is a huge part of that. And so when I say standard work, that's essentially we're saying what we will do, it's written down, and then there's the accountability piece. We do what we say. And when I talk about accountability often, that has kind of a negative connotation, but accountability is simply that we're ensuring that whatever we said we're going to do, people are actually going to do it. And think about this, too, for the leaders on the line. You really can't hold people accountable when you think about it. You can only hold them accountable to something, and that something is the standard work, the formalized processes and procedures. And two, the other point I want to make about accountability is really about habit formation. And so think about this. If I'm developing a new process or a new procedure anywhere within your medical practice, it typically takes about 21 days for a new habit or new behavior to become habit. And that's with consistent leadership focus, frontline leadership, coaching, and monitoring. And the other important point about standard work is we're not just telling people, reminding people what they should do, how they should do it, and when they should do it. We also explain why. Why do they need to do this? And this is very important. So I borrowed these pictures actually from the Studer Group, and they do a lot of work around staff engagement and organizational development. And so I think it's very, very important that we don't just tell people what to do. Actually, they're the ones developing the standard work and fixing the processes. But we also have to connect them with the why. Why is it important that we do things the way we do? One, there's regulatory issues, there's financial issues, et cetera, et cetera. So connecting to the why is very, very important. So I hope you enjoyed my cheesy pictures, but I thought they were funny. I can hear you laughing now. So anyway, the other thing, too, is we want to minimize what I call a culture or an environment of casual compliance. So there's two parts to this. Oftentimes, there's not standard work in place. Our procedures aren't well formalized and clarified to staff. But the other thing, too, is when they are in place, we're not consistently following them. And that's a frontline leadership issue. And so I get a lot of questions about behavior change and managing change, and I'll talk about that here at the end coming up. Well, actually right now, so there you go. So the one thing I tell people, I get asked a lot, how do we get people to do this? How can we get better? And what's the one truism about improving, whether it's your business, your department, or your personal life, and that is that it always requires change. So the thing I like about Lean, the approach we use and the methodologies that we use, is that as a leader, as a practice manager or a physician leader, you're not going in there telling people this is what you're going to do, this is how you do it. They're the ones actually redesigning the work and making the changes. And so when they do that, you generally tend to get less resistance and more cooperation. I don't like the term buy-in. That implies that I'm trying to sell you something and you have to buy it. It's really about collaboration and acceptance. And the other thing, too, very important for leaders to understand, so it's not just about process, it's not just about workflows, it's not just about technology. There's a big leadership component to this as well. And as I mentioned before, when you introduce new behaviors and new processes, it takes 21 days for that new behavior to become habit. But that's the leader's job to make sure that people are consistently performing. And so I like to think about it as when we look at our processes and we embrace some of these lean techniques, we're taking excuses away from our staff, right? We're trying to remove those barriers. We're trying to set up a work environment where there's less frustration, less waste. And the other thing, too, when you talk about change, when we frame the change from the perspective of the patient and not just because the payer wants us to do this or the leadership wants us to do this, it becomes very hard to resist that because everything we do, when you think about it, is about the patient. And then the other piece, too, and it's the obvious piece here, it's the financial imperative. Your costs are going up. Your reimbursement is probably going down or certainly not changing at all. And so that's a reality. And you know, I get asked a lot, how do we have time to do this? No one's going to come to you and give you 10 more hours per week or 2 more hours per day. So some of this stuff you just have to start doing. You just have to basically pick a starting point and go to it. So the other important thing that we tend to see, or critical success factor, when I see a lean practice or a practice that I call optimized, they have what I call a laser-like focus on patient flow. It's every day. It's not just when problems surface, when you get a bolus of patient complaints or physician complaints. So they're using their metrics, their dashboard, they're monitoring patient flow, not just from sign-in time to exit time, but those times in between that make up patient flow. And then they're taking corrective action immediately. They're not waiting. They're going in. They're using that information to correct the problem. And then they also, obviously, they know what their cycle time is. And then the last bullet point I kind of mentioned, so I'll just skip over that. So again, most of my comments, or really all of them, were focused around patient flow, but some of these lean techniques that I briefly touched upon can really be applied to other critical areas of your practice, whether it's chart prep or even revenue cycle management. So what you're trying to do essentially is take these structured techniques or the structured approach and look for wherever there's waste, delays, where timeliness and accuracy and speed matter. I actually not comfortable with the term speed in healthcare. Maybe it's velocity, I don't know. And the reason is because I'm not implying that speed is all that matters. I mean, obviously patient care is always at the forefront. But there's a lot of things that we could do, a lot of approaches that we can take to improve timeliness without sacrificing quality and safety and patient satisfaction, of course. So I'm a tad bit ahead of schedule, which I guess is a good thing, as I tend to talk a lot off slides, but I think I have good slide discipline so far. So I'm going to go over my, I think, 5 key points that I was hoping to convey today. And one is the lean techniques can give you kind of a new approach to process improvement and practice optimization. Now, I just want to stop and mention here, I recognize you didn't become a practice manager or a physician leader because you don't know how to run a practice. That's not what we're doing here. What I'm simply trying to convey to you is that some of these lean techniques and lean methodologies can give you more structure, more discipline and rigor around the art and science of improvement, which is point 5 here. And I find that practice managers and physician leaders often know what to do, but there's a knowing-doing gap or an execution gap. You're not quite sure how to execute, or maybe you need a little more insight. So that's what this is about. And point 2, bouncing back up to point 2, as I mentioned earlier, there's no single silver bullet. It's going to be a lot of little changes that really add up over time that are going to begin to chip away at your cycle time, are going to begin to chip away at some of the waste and maybe improve staff and patient satisfaction. Point 3, I made it earlier. I'm going to reinforce it. Technology is wonderful, but in the end, technology is simply a tool that facilitates the process. Standard work is essential, and consistent frontline leadership is very important as well. So, point 4, pick one process, pick one function, one area, map the flow, identify where the waste is, and select your OPs, your opportunities for improvement. And then, of course, number 5, I mentioned just to reinforce, I think lean gives us a way to better implement and manage and sustain the change than if we just went about ad hoc improvements within our practice. And to me, too, when you think about lean, it's really about reducing what we call the 4 C's of confusion, chaos, complexity, and conflict. Again, lean more than anything to me is about reducing waste and using fewer resources. Now, I just want to reinforce a point here. I'm not sure if I made it before, but I will now. Lean does not imply doing things with less people. It's less resources. And if that means less people, we simply redeploy those people so they can add more value elsewhere in our operation. So lean does not imply reducing people. We get too lean by adopting some of the techniques that we talked about. We don't get lean just simply by slashing. So we have the service offering called TPO, or Targeted Process Optimization. It's essentially a collection of tools, best practices, and advisory services related to general practice operations, whether it's patient flow, revenue cycle management. And we have a dedicated website which you can connect to on mcta.org. And the whole premise behind this is that we spend less time assessing and evaluating and more time on execution and implementation, which means accelerating the rate of improvement. So that's something that you can get more information on from our website. So what we're also going to do for you as well, so we have a practice operational self-assessment tool, And so you'll have access to this. It's simply asking you questions about your practice, about your operations, and we'll use that to kind of give you some context around opportunities for improvement. And I believe that will be emailed to all the attendees as well. And so here's some, the waste identification tool. So if you want that, you can contact me directly as well, or you can contact me directly for the waste identification tool, and we'll get that out to you. But I think the assessment tool will be sent out to you automatically. There you go. So I believe I am finished with my comments. So if there are any questions, I think we'll take the questions.
All right. Thank you, Chris. That was great. We've had a few questions come in. I know on the start of the presentation, we had a few come in asking where the PowerPoint, if they could get a copy of the PowerPoint. I sent out the link again. Hopefully you all saw it. If for any reason you don't have it, you can go to the mceta.org website, click on Resources, and then Webinars. And there's a link to a PDF version of this. There's also links to all of our past webinars, as well as recordings are there too. This one will also be posted there, recording in the coming days as well. A couple of other questions that came in throughout the presentation. One, direct to Chris here. If I were interested in looking at our practices process for areas of improvement, what does the level of effort look like, and how many hours does it take?
That's a great question. So that essentially is an offline discussion, but to address the question, that is a function of the scope and scale of what you're trying to do, how many practices we're talking. That's something that we'd have to have a discussion offline. But it would depend, again, on the scale, scope, number of locations, and I guess the complexity, and then we kind of work out what we think what it will require in terms of level of effort and resources and in terms of people hours.
Okay, great. Next question. In your experience, what is the biggest barrier to getting processes changed?
Now that's an easy one, and I get asked that a lot. Well, there's actually two parts of that. One is time, and I mentioned in my comments during the presentation that no one's ever going to give you more time. There's never going to be a better time to improve, so you just have to pick a starting point. So that piece is often difficult. But you got to remember, if you keep doing what you're doing, you're always going to get what you're getting. So you just have to commit to making the time. The other part to that, and I think more importantly and more common, is behavior change. And so I talked before about whenever we implement something new, we introduce change. It takes a number of days, 21 days, for a new behavior to become habit. So changing behavior is very difficult. However, in the places where it's more effective and more successful, there's a couple commonalities that I tend to see. One is consistent frontline leadership, clear expectations, standard work, well-defined procedures, the use of visual tools such as checklists, key reminders, etc. And then also connecting people to the why. Why are we changing? Why is this important? Because in healthcare, we do a good job sometimes of pointing people in the right direction in terms of how they should do things. We don't always connect them to the why.
Good. All right. Next question. And again, if you have a question for Chris, please use the chat function or the questions function in your GoToWebinar interface, and you can submit that to us. Next question is, what if we are doing some of the procedures you mentioned? Is there still room for improvement?
We're always improving, hence the term continuously improving. So there's always room to improve. And so if you're doing any of these, I would consider, were there any takeaways from this presentation, or reach out to me for additional insight, because I think there's always opportunity to keep improving what we're doing. Is that helpful?
Yes, thank you. Next question. Is there a standardized tool for collecting cycle time data for the outpatient setting?
That is a good question, and I'm actually working on one right now. So the short answer is yes. The other short answer is not right this minute, but I should have one hopefully by the end of the week. So, and also, So I referred to our TPO website. That's the kind of stuff that will be available on our website. But that particular tool is not available. I did mention in our, let me go back here. Are we still? Yeah, go ahead. So I did mention that we were going to push out that self-assessment tool. The other part is the last bullet point, a patient flow toolkit, which I'm currently developing. And so that patient flow toolkit would have that particular tool. But whoever asked the question, if you want to connect with me later on in the week, I should have something ready to go. But that was a great question.
Great. I have another one that's actually kind of spells out a scenario. So let me read this one to you. We have a small practice where all staff practically help each other to make things efficiently. However, of course, we all have our own quote-unquote major everyday today duties. Recently, getting some negative reaction from 2 employees butting heads about who does what. I do not want to have to carve out the actual list of job duties per employee, as this will create a "that's not my job" type of workplace. How do I handle this issue, approach these employees, and get rid of this negative behavior? That's a big one.
Yeah, that's a big one. So let me try to break this down. So a couple things here. You bring up a good point about the size of a practice. So the smaller a practice is, and this is another lean concept that I didn't touch upon, and that's the concept of cross-training. The smaller your practice is, the more important it is that you cross-train, which means that if I have someone working in registration, they can also do vitals. Or so, I mean, you're expanding job roles. So I think it's important that we define what you expect people to do in terms of their daily tasks, but I also think it's important that they understand that you're going to be asked to do other job duties outside of your core, your primary functions. And I think if we connect them to the why in terms of, hey, we can't hire more people, right? So we need to chip in and help other people. We need to expand our job roles. And I think, too, part of that's going to take consistent coaching. So I would just, this sounds simple, but it really is a function of having a crucial conversation with people saying, this is what I expect as a leader. This is what I expect from you in terms of expanding job duties, cross-training. This is why we need to do that. However, your core job, whether it's 60% registration and scheduling or 60% taking vitals or whatever, you do need to clarify that and formalize it. And I think, too, when you start implementing change, 1 or 2 things are going to happen. People are going to maintain their current behavior when the reward or incentives, well, I don't want to say reward incentive. We're trying to be cost neutral. People are either going to change or they're going to move along. And really it's that simple. So I'm not sure if that was helpful, but a lot of times I know as leaders we don't want to be prescriptive in terms of like we're creating a recipe of what we want people to do, but you really have to. You really have to, because you want to take away excuses, as I mentioned earlier. And the key point here I want to reinforce is that when you have a small practice and you're constrained in terms of hiring people, you need to cross-train. That's just the way. That's just the reality. So I'm not sure if that was helpful, but if you, whoever asked the question, if you want to contact me offline, I'd be glad to give you more insight.
Thank you, Chris. I think that I don't have any other questions coming in at this time. I think we're getting to the end here. Again, we have Chris's contact information. You can certainly feel free to reach out to him if you have any other questions that you think of after this broadcast. All of the questions and answers will be put together in a digest and emailed out to all the attendees in the coming days. There will be a recording of this broadcast on our website as well. Go to mceta.org, go to resources, and then webinars. All our past webinar information is there. Also, we have 2 scheduled upcoming webinars that I urge you all to go ahead and register for as well. On April 16th, we'll be doing a webinar about the Million Hearts Initiative, and more specifically, some new developments in Michigan here, and some great stuff that we're working on around hypertension and controlling and a registry and some really great work. So please tune in on April 16th for that. On May 7th, we will also be conducting a webinar on the security risk assessment. So I know that's a big topic, a big topic of fear even amongst providers and practices. So please tune in on May 7th for some great information around the security risk assessment as well. And again, I want to thank you all for attending today's webinar. And if you have any further questions, you can reach us by going to our website and engaging us there. You can also give us a call. We'd be happy to help. With that, thank you very much.